Now, I'd like to welcome on stage Dr. Alan Zhu from University of Chicago to present the next abstract. Thank you.
Session chairs, ASCO colleagues, and guests, I am a third-year medical student at the University of Chicago. And on behalf of my co-investigators, I would like to thank you and the Scientific Programming Committee for the honor of presenting the results of our study on the association of somatic mutations, histologic subtype and grade on prognosis and PD-L1 expression in mesothelioma. And I have no disclosures. To start off, for a pathologist, mesothelioma is morphologically similar regardless of the site of disease. And despite its uniform appearance, it is known to be heterogeneous at the clinical, histologic, and molecular levels. And while there are many ways to evaluate mesothelioma, the relationships between histology, mutation profile, and clinical characteristics are not all that well understood. Histologically, mesothelioma is categorized into one of three subtypes: epithelioid, sarcomatoid, or biphasic, which is a mixture of the first two. Histologic subtype correlates with survival, as mesothelioma patients with epithelioid histology have a longer survival than patients with biphasic histology, which is longer than sarcomatoid. Epithelioid mesothelioma is further categorized into three nuclear grades. This classification system uses grades 1, 2, or 3 to indicate low to high grade, as seen in these images. And this nuclear grade has been shown to correlate with survival in multiple studies. Overall nuclear grade in epithelioid mesothelioma is a composite of nuclear atypia and mitotic index. Atypia is scored based on the uniformity of the nuclei, whereas mitotic index is scored based on the number of mitoses in 10 high-powered fields, which is a marker of actively dividing cells. Each of these components is scored 1 to 3, and they're added to give an overall nuclear grade. This nuclear grading system has been validated by a large multi-institutional study and is also used to stratify epithelioid mesothelioma into prognostic categories. Now, the most frequently occurring somatic mutations are in tumor suppressor genes. These include BAP1, CDKN2A, NF2, MTAP, and TP53. So sequencing has also shown that tumor mutational burden is lower in mesothelioma than most other cancers. PD-L1 expression in mesothelioma is thought to be prognostic for poor survival. It's found to be higher in non-epithelioid histologies, and it does not appear to correlate with response to immunotherapy in certain studies. Now, we know that pathologic factors such as nuclear grade may inform prognosis. But despite the utility of multiple prognostic indicators, it's not clear how those indicators relate with key pathologic factors. So a refined understanding of mutational status and histopathologic features may improve our management of mesothelioma. Therefore, the goal of our study was to identify how features in histopathology and genetics correlate with one another and with clinical outcomes. We examined histopathologic features such as grade, subtype, and PD-L1 status, as well as mutations from tumor genomic sequencing and clinical characteristics and outcomes. And we'll present our findings on the relationships between these different aspects of mesothelioma biology. Now, this study was part of a prospective IRB-approved biobank study. And at the time of data analysis, 530 patients with mesothelioma had been enrolled from 2016 to 2022 into a biorepository of tumor and normal specimens. We also had collected demographic, social, and clinical characteristics. Of these cases, 217 were selected for analysis. To be included, patients must have met two criteria. First, they must have had next-generation sequencing of their tumor, and second, they must have had at least 6 months of follow-up. And then data such as age, gender, ethnicity, asbestos exposure, personal and family history of cancer, site of disease, treatment, and survival were also collected. All tumors had histological studies done, which included H&E staining, classification of histologic subtype, nuclear atypia, mitotic index, nuclear grade, and PD-L1 IHC staining. Tumors also underwent molecular characterization using next-generation high-throughput sequencing with an in-house panel that sequenced over 1,200 cancer-related genes. Sequencing also reported tumor mutational burden. In addition, research-based germline testing on 85 genes was also performed. And from all these results, we performed statistical analyses to examine correlation and survival. We now discuss some patient demographic and clinical characteristics. First of all, the median age at diagnosis was 66 years. And as expected, the majority of patients were male and Caucasian. Most described self-reported asbestos exposure, and 25% had a personal history of cancer, another cancer, and 70% had a family history of cancer. As expected, the majority of our patients had a pleural site of disease origin, and of note, 16% of our patients had a germline mutation, and about half were alive at follow-up. Histologic characteristics are shown here. Most samples were epithelioid in histology, and most epithelioid mesotheliomas were nuclear grade type 2. Additionally, tumor and lymph node stage were also displayed for resected tumors, and resected tumors were well distributed from PT1 to PT4, and most were PN0 for lymph node stage. Somatic mutation frequencies are displayed here. The most common mutation was BAP1, which is present in 45% of cases, followed by NF2, TP53, CDKN2A, and TERT. While there are other mutations present, we focused on just these 5 most abundant somatic mutations for subsequent analyses. We also analyzed germline mutations. 34 patients, or about 16% of patients in our cohort, carried a total of 39 germline mutations. And as expected, BAP1 mutations were the most frequent, followed by CHEK2, ATM, and MUITH, with the remaining genes listed occurring only once. Now we transition to our statistical analyses, starting with survival analysis. As one might expect in a mesothelioma cohort, female gender and epithelioid histology, outlined by the black Kaplan-Meier curves in the figures, are associated with a longer survival. We also found that mesothelioma originating in the pleura has a shorter survival than non-pleural mesothelioma. And consistent with previous studies, we see that a higher nuclear grade trends with shorter survival. And we next found that PD-L1 expression is not prognostic for survival. We next examined whether somatic mutation was related to histologic subtype and found that only CDKN2A and TERT mutations are more prevalent in the sarcomatoid mesothelioma. We next asked which somatic mutations could affect survival, and we found that both TP53 and CDKN2A somatic mutations are associated with survival, shorter survival, as seen in these Kaplan-Meier curves. Within epithelioid mesothelioma, we compared mutation status to nuclear grade, and we found that TP53 is more likely to be found in a higher nuclear grade. And although CDKN2A is associated with a shorter survival and more aggressive subtype, as shown in previous slides, interestingly, it's not associated with a higher nuclear grade. We then looked at the overall proportion of cells in a tumor sample that were PD-L1 positive and found that epithelioid mesothelioma also exhibits less PD-L1 expression than the biphasic or sarcomatoid subtypes. While PD-L1 is associated with a more aggressive histologic subtype, in epithelioid mesothelioma, PD-L1 expression is not associated with a higher nuclear grade. We then asked whether somatic mutations are related to PD-L1 expression. PD-L1 expression is not associated with any of the common somatic mutations we examined, as displayed in this table. We next wondered if genetic mutations were more likely to be found in a particular site of disease. TP53 somatic mutations are found to be more prevalent in pleural than peritoneal mesothelioma. We also examined how mutations relate to tumor and lymph node staging. Mutations in TP53 were more prevalent in the PN0 lymph node stage, meaning no metastasis. Genomic sequencing also provided the tumor mutational burden of each sample, listed here as the number of mutations per megabase. And between samples that were positive or negative for a mutation of interest, we found that BAP1 and NF2 positive tumors showed a higher mutational burden. And finally, we performed a multivariate regression analysis using predictor variables that were found to be significant in the previous univariate analyses we showed. This could help us determine the relative contribution of each of those variables towards survival. And our studies, as shown here, suggest that the histologic subtype, somatic TP53 mutation, and gender are the strongest, most independent predictors of survival. So in conclusion, we performed a correlational study between histopathologic, molecular, and clinical characteristics of mesothelioma. And our key findings include the following. TP53 somatic mutation is associated with shorter survival, PN0 lymph node stage, higher nuclear grade, and pleural site of disease. PD-L1 expression is lower in epithelioid histology. CDKN2A and TERT somatic mutations are more prevalent in sarcomatoid histology. CDKN2A somatic mutation is associated with shorter survival, but not nuclear grade. Epithelioid histology, TP53 somatic mutation, and gender are the strongest predictors of survival. And thus, nuclear grade is useful for prognosis, but other factors such as somatic mutations should be taken into consideration. Now, limitations of this study include that it was retrospective, had a relatively small sample size of 217 cases, and was done at a single institution. For future directions, the contributions of germline mutations, which occurred in a substantial proportion, 16% of this cohort, are being explored in an ongoing analysis. The impact of treatment, including immunotherapy, germline mutations, asbestos exposure, and other factors will be evaluated and incorporated into multivariate analysis. Overall, I hope you found that understanding the associations between these prognostic factors may improve our management of mesothelioma. And I'd like to sincerely thank the patients and their families who participated in their study, as well as the University of Chicago, specifically the MSTP for funding my training as a medical student, my co-investigators from the Departments of Pathology and Medicine, and my colleagues in the Mesothelioma program. As a medical student, I am very grateful for my mentors in the pathology department, Professor Aliyah Hussein and my resident Dr. Mike Kwan. And in the medicine department, I would very much like to thank Professors Hetty Kindler, Michael Drazer, and Research Coordinator Owen Mitchell. And I thank you all for your time and attention.
We invite Dr. Marjorie Glass-Soderer from Memorial Sloan Kettering.